All righty, so let's just start out with number one, integumentary system. Number one, Joe has a terrible problem with ingrown toenails. He goes to the podiatrist to have a nail permanently removed along with the nail matrix. So with this one, since we only have one code in each of our answers, let's actually look this up from scratch instead of doing process of elimination. So our procedure that we are doing would be what? The removal. Yep. So we'll go to removal and then nail. And that gives us a range of codes, the 11730 through 32, and then the 11750. So let's go to the 11730 through 32, and then 11750. So our 11730 is an avulsion of the nail plate, partial or complete, simple. And then it's for a single, 32 is for an additional nail plate. And then we have 11750, which is the excision of the nail and the nail matrix, partial or complete. And the examples are for an ingrown or deformed nail, and it's a permanent removal. So, yep, Tansy's correct. 11750 is going to be our code. Any questions on that one? Okay. Let's do number two. Let's do this one from a process of elimination standpoint. So we have two options that have the 17,000. We have three options that have 17,003. And then we have two that have 17,110. So my thought process, because these are early in the, not early, but these are in the beginning. They're both first listed codes. That's where my eyes went to first. So let's go to 17000. And we're doing destruction of 16 premalignant lesions and then 10 benign lesions. So 17000 is for the destruction, which includes laser surgery, electrosurgery, cryosurgery, chemosurgery, and surgical curettement. And they are for premalignant lesions. So we've got we've met that portion. But this is for the first lesion, and we have 16 total. So let's look at the 17003 underneath. Well, actually, we can rule out A and C, right? Because we know that 17000 is not it. 17003 is for the second through the 14 lesions, but we have 16 total. So let's look at the 17004, and that's for destruction of your premalignant lesions, 15 or more. So we know we need 17004 because that is 16 of our premalignant lesions that are being removed. Now, if your eyes don't always, oh, I just did that. If your eyes don't tell you that you need to go to 17004 because it's on a totally different page and you have to flip it, I have in my book written underneath 17003, if 15 or more, see 17004. So that way it's just another visual reminder to tell you to go see that next code if you have 15 or more. So we know that the 17004 is our code. So we don't even have to go look up the 17110. But that 17110 would be the 10 benign lesions if we were to go look at it. Okay. Any questions on that one? Okay. Number 3, patient is here for follow-up of a keloid that was excised from his neck in November of last year. He does believe that it's coming back, and he has a recurrence of the keloid on the on the superior portion of the scar. Because the keloid is still small, options of an injection or radiation to the area are discussed. It was agreed that our next course should be Kenalog injection, and the risks associated with the procedure were discussed with the patient. Informed consent was obtained, and the area was infiltrated with 1.5 cc's of medication. And that mixture was of 1 cc of Kenalog 10 and a half of a cc of 1% lidocaine with epinephrine. And he tolerated the procedure well. So, from a process of elimination standpoint, do you want to do not ICD-10? Do you want to do HCPCS or do you want to do CPT? I guess we could do it from ICD-10 as well. Which one do you all want to go with tonight? Because I know that we haven't really done a whole lot of HCPCS. Okay, so TMZ says HCPCS. So let's pull out our HCPCS manual. We have J3300 and J3301. So let's go look at a difference, see what the difference is between J3300 and J3301. So for this one, which one do you think it should be? One is for preservative free, and then one is not otherwise specified. J3301. Yep. So it's for the injection of the triamcinolone acetonide, not otherwise specified, and it's for 10 milligrams. And your drug names underneath, you have Kenalog, Kenalog 10, Kenalog 40, Kenalog 80, or that triamcinolone acetonide. Okay. So now, do you want to go ICD-10 or do you want to go CPT to figure out if it should be B or D?
I'm sorry, Tiffany, to bother.
Yeah.
What page was the G3301? I just got out my HCPCS, but I can't seem to find it.
Do you have the 2024 AAPC?
Yes.
It is on page 321.
Oh, wow, I'm on 496. Okay, thank you.
You're welcome.
Yeah, I was way off.
Oh, yeah. So
Thanks.
you went, okay. So if you had gone to the table of drugs and biologicals, so let's talk about that for a second. Had you
Okay.
gone to that, then you would have gone to triamcinolone. I can't even talk tonight. Acetonide. And then it would be the second one from the bottom on page 497.
Oh, perfect. Okay, but you recommend going to not go to the table of drugs.
From a testing perspective, yeah, you can go directly to the code.
Okay.
Yep.
Thank you.
You're welcome. Absolutely. Okay. So let's do the CPT. So let's look at the actual injection, right? So our J3301 is indicating the drug that was injected, which is that Kenalog 10 or that triamcinolone acetonide. And then we need the actual act of the injection because we not only need to get reimbursed for the medication, but for the MA, the nurse, whoever it is that's doing the injection. So I guess in this instance, it's going to be the provider. So in this one, we are looking at 11900 or 11950. So 11900 is for an injection intralesional up to and including 7 lesions. And then 11950 is our subcutaneous injection of filling material, 1 cc or less. So the question is the substance that we are injecting, is that a filling material or is it just going to be an intralesional injection? Any thoughts?
Just the injection?
Yep. It's going to be an injection intralesional because if we're trying to break down the
Mm.
keloid, then we are not going to be doing a filling material because that's just going to plump it up, right? So if we are trying to break it down in order so that that keloid will go away, then we should just bill or code for the injection that was done intralesionally. Okay, does that make sense? Any questions on that one?
So there's
Okay.
nothing that
Nope.
really says that it's filling or not technically. It's just you got to use common sense. It's a keloid, you wouldn't want to fill it.
Right. Yeah, you just have to know what a filling material would be and then kind of what we're doing with the injection. Yeah.
Okay. Thank you.
Yep. You're welcome.
In these
Alrighty.
cases, I wish that CPT had guidelines.
I
Just like
know,
the
I know. And
ICD.
some of your areas do have guidelines. Like you can see like your repair and closure that's on the next page, but not every single little section is going to have guidelines. So that's, yeah, I know. I wish they did too. Okay. Let's do number 4. So patient presents to the physician for the removal of a squamous cell carcinoma on the right cheek. After the area is prepped and draped in sterile fashion, the surgeon measures the lesion, and the documented size of the lesion is 2.3 centimeters at its largest diameter. Additionally, the physician took margins of 2 millimeters on each side of the lesion. Single layer closure was performed, and the patient tolerated the procedure well. So, from a process of elimination standpoint, okay, we have 2 that have 11643. So let's go find our 11643. This is for an excision of a malignant lesion, and it is based on an anatomic location. So face, ears, eyelids, nose, and lips. And we are on the right cheek. So that's going to be on the face. And then the 643 is for an excise diameter of 2.1 to 3.0 centimeters. So versus the 11642, which is 1.1 to 2 centimeters. So we're gonna, which one do you think we should use? Yep, Dawn. We should use the 11643. So we are gonna rule out A and D. And then the question begs, are we coding the closure separately?
I would assume so, since it was a separate procedure.
Okay. If we go look at our guidelines at the beginning of the excision of malignant lesions category or subcategory, it's on page 91 if you have the 2024 CPT. And in your 3rd paragraph, 2nd sentence, it states repair by intermediate or complex closure should be reported separately. So that's basically telling us that a simple closure is going to be included, and we should only separately report a complex closure or an intermediate closure. So since it was a single layer, that's going to be considered a simple closure. So we're not going to code that separately.
And then he took an extra 2 millimeters on each side. And so that's like 0.4. Then you add that to the 0.23 is 2.7.
Mm-hmm. Yep. Yep.
Okay.
So you have to take your lesion size plus your margins. So yeah, since they took an additional 2 millimeters on each side, then it would be, yep, 0.4 because it's technically a millimeter is 0.1, right? So this is where they're trying to get you to see if you're recognizing that it's a millimeter versus a centimeter. Yep.
Thank
And
you.
then, yep, you add those in. So it would end up being a 2.7. You're welcome. Any other questions on that one? Okay. Number 5, Meredith has breast cancer on the left side, diagnosed by an excisional biopsy that was performed last week. Today, she's having a radical mastectomy, urban type, and concurrently a single pedicle tram flap reconstruction with supercharging. So, from a process of elimination standpoint, we have 3 that have 19368. And then everything else is a single. So let's go look at our 19368 just to confirm. More than likely it is, but you never want to assume it is and not go look at it. So your 19368 is going to be for the breast reconstruction with a single pedicled transverse rectus abdominis myocutaneous, also known as a tram flap, requiring separate microvascular anastomosis, and that is also known as supercharging. So there's our tram, the single pedicle tram flap reconstruction with supercharging. Okay. So then let's go look at, these are all going to be right there together, right? 19302, 19305, and 19306. So 19302 is a partial mastectomy, but we did radical, right? So that is going to not be it. 19302 is ruled out. 19305 is a mastectomy radical, including pectoral muscles, axillary lymph nodes. So that includes our radical mastectomy portion. But don't stop there. Let's go look at 19306. That is for a mastectomy radical, including pectoral muscles, axillary, and internal mammary lymph nodes. And that's also known as an urban type operation. So our urban type is going to be the 19306. So if you had answered 19305, your provider would have been underpaid a little bit because they didn't do, or if the 19305 is only the axillary lymph nodes, and then the 19306 includes the internal mammary lymph nodes as well. Okay. Any questions on that one? Okay. Number 6, patient is an 81-year-old male with a biopsy-proven basal cell carcinoma of the posterior neck just near his hairline. Additionally, the patient had 2 other areas of concern on his cheek. Informed consent was obtained, and the areas were prepped and draped in the usual sterile fashion. Attention was first directed to the basal cell carcinoma of the neck. I excised the lesion, measuring 2.6 centimeters as drawn down to the subcutaneous fat. With extensive undermining of the wound, I closed it in layers using 4-0 monocryl, 5-0 proline, and 6-0 proline. The wound measures 4.5 centimeters. Attention was then directed to the other 2 suspicious lesions on the cheek, and after administering local anesthesia, I proceeded to take a 3-millimeter punch biopsy of each lesion and was able to close with a 5-0 proline. The patient tolerated the procedures well. Pathology later showed that the basal cell carcinoma was completely removed, and the biopsies indicated actinic keratosis. So process of elimination standpoint, we have 2 that have 13132. So our 13132, that is for a complex repair on the forehead, cheek, chin, mouth, neck, axilla, genitalia, hands or feet. And then it's for 2.6 to 7.5 centimeters. So we did do a closure that was 4.5 centimeters. They did do extensive undermining and they closed it in layers. So is that going to constitute a complex closure? Yep. If you don't know what is included in simple versus intermediate versus complex, you do have your guidelines on pages 94 and 95 in the 2024 manual that will tell you what is included in each of those 3 different types. Okay. So we know we need the 13132. So we're going to rule out B and C. Your 11623 and 111, nope, it's not. I almost did what I did last time. You have 11104. Make sure you don't do this and do what I almost did. And you have 11440. Okay, they're going to have similar codes in there to see if you're paying attention to that. So let's go look at the 11104. So your 11104 is a punch biopsy of the skin, single lesion. And then the 11440 is excision, other benign lesion, including margins, except for a skin tag on the face, ears, eyelids, nose, lips, and mucous membrane. And the excise diameter is 0.5 centimeters or less. So for the second, the 2 lesions on the cheek, the 2 suspicious lesions on the cheek that were 3 millimeters, are we going to report the biopsy? Or are we going to report an excision? Yep. We're going to do the 11104 because they stated that it's a punch biopsy. Okay. So we know it's going to be A.
Hi, Tiffany. I had a
Yeah.
quick question, and I don't want to hold up the class too long.
No, you're fine.
I was wondering, for distinct services for modifier 59, do you think you can explain how we could identify that in this scenario?
Yep. Because in this scenario, we have a 51 and a 59. So this is a good scenario to help show you, right? So 11623 is going to be for the excision that we did up here where we took out the basal cell carcinoma, right? So if we did an excision and then a closure of the same site, that's going to be multiple procedures on that same site. Whereas the 59 for your punch biopsy is because it was on a totally different lesion, totally different area. So 51, because it's multiple procedures on the same lesion or the same location of the lesion, right? 59 is because the lesions were they were totally separate lesions. Does that help?
Yeah, that helps a lot.
Okay.
Thank you.
You're welcome. I know 51 and 59 can get really confusing. Okay. Any other questions that you guys can think of? Okay. Number 7, patient presents to the emergency department with multiple lacerations from a knife fight at the local bar. After examination, it was determined that these lacerations could be closed using local anesthesia. The areas were prepped and draped in the usual sterile fashion. The surgeon documented the following closures: 7.6 centimeter simple closure of the right forearm, 5.7 centimeter intermediate closure of the right upper arm, 4.7 centimeter complex closure of the right neck, and then a 10.3 centimeter intermediate closure of the upper chest. So from here, let's actually look at this critically thinking wise, not necessarily process of elimination for this one. Okay. So when we have multiple lacerations that we are closing, okay, if we have different types of repair, meaning some are simple, some are intermediate, some are complex, which one should be listed first? Which one should be sequenced first? Your complex, your highest one. Yep. Your most complex procedure is going to be your complex closure. Okay. So we have a complex closure of the right neck. Okay. So let's look at the 13132. And that's going to be a complex repair: forehead, cheek, chin, mouth, neck, axilla, genitalia, hands or feet, 2.6 to 7.5. So here we have our 4.7, right? So we know that the 13132 is first. Okay. Now our intermediate closure. We have a 5.7 centimeter intermediate closure here. And then we have a 10.3 on the chest. So which one of these two should we list first? So should we list the upper right arm first, or should we list the upper chest first?
Yeah, for chest.
Yep, because it's the larger one. It's the 10.3. Okay. So let's go look at the 1, 2, 0, 3, 4, 3, 5, 3, 6 and determine which one it should be. So 1, 2, 0, 3, 4 is for scalp, axilla, trunk, and extremities, excluding your hands and feet. 7.6 to 12.5. Then we have 12035, 12.6 to 20.0, and 12036 to 20.1, it's 20.1 to 30.0. Now, here's the trick. Yep, Dawn, you got ahead of me, which no, it's totally fine. But the trick, or not necessarily the trick, this is where you have to know your guidelines. If you read our anatomic locations, we have scalp, axilla, trunk, and extremities. Your upper chest is your trunk, and then you've got your upper right arm, which is an extremity, right? So technically, we should add these together because they are the same anatomic grouping at the same level of complexity. So they are intermediate closures and the same anatomic grouping. So we have to add the 10.3, so the 10.3 and the 5.7. So how many total centimeters for that anatomic grouping for the intermediate repairs do we have? Total centimeters, 16. Yep. So if we have 16 centimeters, it's going to be your 12035. So they were trying to trick you because they were trying to see if you would report them separately, right? So just remember, don't just look at each one of them individually and code them individually. You have to make sure that they're not in the same anatomic grouping that you can. Okay. Any questions on that one?
Yes, sorry. Sorry, asking a lot of
No, you're
questions
fine. You're
tonight.
fine.
What page was that guideline on?
Your guideline as far as adding them together,
Yeah.
it is page 95.
Okay.
It's underneath the extensive undermining. I guess it's called an illustration. I guess that would be considered an illustration, and it's number 2.
Okay,
So it says
perfect.
when multiple wounds are repaired, add together the length of those in the same classification and from all anatomic sites that are grouped together within the same code descriptor.
Perfect, thanks. Yeah, I noticed most of these questions are pretty tedious. Like you really have to read through,
Yeah.
It's definitely
There's
tricky.
going to be some of them that are going to be pretty straightforward, but then there are going to be some of them that you will have to think about for sure.
Yeah.
Yep. So I would much rather go over the ones that are going to be a little bit more tedious and a little bit more intense whenever it comes to making sure you know your guidelines, because if you can do these, you can do the ones that are pretty straightforward. Absolutely. So there's a question in the chat about if we have a fill in the blank on the exam, do we need to indicate LTRT? For closures, you do not have to indicate LTRT because it's all in a big grouping anatomically wise. So you would not have to. Now, if you have a code, just in general, let me see if any of these, I don't think any of these had any that we would do, because this one is the neck. This one's a cheek. Yes. So like number 5, if it's a fill in the blank, you would have to put your LTs on there. Okay. Any other questions? All right, let's look at number 8. So patient is here because the cyst in her chest has come to a head and it's still painful even though she's been on antibiotics for a week. I offered to drain it, and after obtaining consent, we infiltrated the area with 1 cc of lidocaine with epinephrine, prepped the area with betadine, and incised and opened the cyst and relaxed skin tension lines of her chest and removed the cystic material. There was no obvious purulence. And we are going to have her clean this with a Q-tip. We will let it heal on its own, and eventually I will excise it. I will have her come back a week from Tuesday to reschedule the surgery. So what are we going to report for this scenario? So this one is asking both ICD-10 and CPT. So let's look at it from a CPT standpoint, because I think, there's not really any good way to really do a process of elimination with this. So if you want to go to the alphabetic index, you can do incision and drainage. So let's do this one from a scratch standpoint. So let's do incision and drainage. This is on a 5th. And then it is within the skin. And then that sends us to codes 10040, 10060, and 10061.
Where'd you find this? I'm on incision and drainage, and then where do I find it?
And then cyst, and then skin.
I see.
So 10040 is going to be an acne surgery. 10060 is an incision and drainage of an abscess, simple or single. And then 10061 is an incision and drainage of an abscess, complicated or multiple. So do we think this is going to be acne, a simple incision and drainage of an abscess, or a complicated or multiple? So 10040, 60, or 61.
Simple.
Yep, it's going to be simple. So 10060. And then since that's our only one, we know that's our answer.
What's the difference between the incision and drainage of the cyst versus the puncture aspiration of the cyst?
The puncture aspiration is going to be more like a needle. So they're going to not do an actual incision and drainage. The aspiration is they're going to put a needle in and draw out the fluid through the syringe.
Oh, okay. Thank you.
Yep. You're welcome. Anytime you see that term aspiration, then I don't want to say 100% of the time, but 99.9% of the time, that's telling you that they're just doing like a puncture and they're not doing an actual like incision and cutting it open. Okay. Any other questions? All right. Let's move to number 9. A localization wire placement in the lower outer aspect of the right breast was performed by a radiologist the day prior to this procedure. During this operation, the surgeon created an incision through the wire track, and the wire track was followed down to its entrance within the breast tissue. A nodule of breast tissue was noted immediately adjacent to the wire, and the entire area was excised by sharp dissection, sent to pathology, and then returned as a benign lesion. Bleeders were cauterized and subcutaneous tissue was closed with 3O Vicryl. The skin edges were approximated with 4O subcuticular sutures, and adhesive strips were applied. The patient left the operating room in satisfactory condition. So what are going to be our codes for the surgeon's service? So this one we have 2 with 19125. So let's go take a look and see what that code description is. And that is going to be excision of a breast lesion identified by preoperative placement of radiological marker. And it was done open on a single lesion. So we did have the nodule of breast tissue noted immediately adjacent to the wire. So that was going to be identified by that pre-op placement of that wire. And then it was returned back as a benign lesion. So we need our 19125. Now the question is, do we also need 19285? So 19285 is going to be for the placement of breast localization devices percutaneously first lesion, including our ultrasound. So are we also reporting the placement of that breast localization device?
I would say yes, because it says here if an open excision of breast lesion is performed after image-guided placement of localization device, code the appropriate localization device, and 19285 is one of them.
Where are you seeing that guideline?
I see it on 112. Oh, wait, maybe this is, 112, page 112.
Okay. Is that localization device being placed today?
Oh, wow, that was a tricky one.
Yep. So this is a totally separate operation,
Okay.
whereas this was placed the day prior to. And it was placed by a radiologist, not the surgeon. So that's your other indication there, that we are only coding the surgeon's servant.
Okay.
Yep. Yep. So that's just another thing that we need to make sure that we're not reading through the scenario too quickly and missing those day prior by the radiologist, and we're only coding for the surgeon. Yep.
Okay.
Okay. Any other questions? Don't worry, Tansy, you are not the first one to do that, and you will not be the last one. Okay.
Oh
So
goodness.
don't feel bad. Don't
This
feel
is so
bad. These
tricky.
are
Like
all
all the
really tricky ones, and I've chose
yes.
these in here for these reasons because they're all pretty tricky.
Well, thanks. This is good practice.
You're welcome. So, Lindsay, is it typical to get a path report during operation to determine that it's benign or not? Sometimes it comes back during, sometimes it comes back after. It just depends on how quick the pathology lab is, to be totally honest. Even if they specifically state that it was an intraoperative pathology, then whenever we go to report the actual pathology section, like for the actual pathologists themselves on a separate claim, that's going to indicate whether or not we need to use just a regular pathology code or if it has to be that intraoperative pathology code. But that's not really going to affect our surgeon's claim per se. Yeah, I know. It's not difficult to get it mixed up, so don't feel bad about that. Okay. Let's do number 10. So we have a 56-year-old pro golfer that is having Mohs micrographic surgery for skin cancer on his forehead. The surgeon performs the surgery with 2 stages. The first stage includes 4 tissue blocks, and then the second stage includes 6 tissue blocks. So we're going to code for both stages. So let's go look at the 17311. So 17311 is going to be for your Mohs micrographic surgery. And I'm going to kind of skip that whole big thing of the thing. But the anatomic locations are head, neck, hands, feet, genitalia, or any location with surgery directly involving muscle, cartilage, bone, tendon, major nerves, or vessels. And then first stage up to 5 tissue blocks. So our first stage had 4 tissue blocks. And then it's on the forehead. So that falls within our anatomic location, as well as first stage with the correct number of tissue blocks. So we need 17311. So we're going to rule out B. Then let's go look at 17312 to determine, do we need another stage? So we did have a second stage that includes 6 tissue blocks. So we do need 17312 because that's our additional stage, and that includes up to 5 tissue blocks. And we had 6. So let's go look at that 17315. Our 17315 is going to be our Mohs micrographic technique. And then I'm going to skip all of the includings. And it's each additional block after the first 5 tissue blocks for any stage. So because we have 6 tissue blocks in the second stage, we need to report 1 unit for that additional tissue block with the 17315. Because our 17312 only includes 5, right? So if we only have 5 that are included with the 17312, we need to report 1 unit of 17315 for our 6th block. Now, had we done 7 blocks, we would do 17315 times 2. But so it's up to, or each additional after the first 5, any stage. Okay. Any questions on Mohs micrographic? Now, don't forget with Mohs, they have to act as both the surgeon and the pathologist. So if at any point they indicate that they are sending the specimen off to pathology, they are no longer performing Mohs micrograph because they have to perform both the surgery and the pathological component in order to bill your Mohs micrographic surgery. That's the biggest thing that a lot of people get caught up on with Mohs is you cannot report on the same specimen your pathology code, your 88301 through 88307, I believe is what it is. You cannot report those separately. Okay. Any questions that you guys can think of?
I do have a question, and I'm sorry, I'm just filled
No,
with questions
you're fine.
tonight.
You are fine. That's what we're here for.
So I am not a good test taker just because I like to really spend like 10 minutes on each question. I know that's a lot of time, but like I just love to reread questions a lot. What's some tips where because I notice if I spend shorter on the question, then I'm like just reading through like most of the important information. Like, what are your tips for like being efficient, but also like making sure I get those key terms to like get the answer right?
So like if you have a larger like question like this, or if it's a case study, like is that kind of what you're talking about?
I'm sorry, what was that, Jennifer?
No, you're
Sorry, I had
fine.
a
Are you
distraction.
talking about like your larger questions or your case studies?
Yes.
Okay. So
Yeah, the
the
larger one.
biggest thing that I like to recommend is look at your codes first and actually look at your code descriptions first. Because if you're looking at your codes and you know what keywords are in your codes, then that's going to help you as you're reading your long scenario. And that way you're not going to have to read your entire scenario, look at your codes and go, well, I don't remember if those words were in there, right? So if
Yeah.
you look at your code and your code description before you even read your question, then that will help you pick out your key terms as we come in here to the scenario.
Okay, thank you. Yeah,
You're
that's just
welcome.
like my biggest, I guess, I've just never been a good test taker. And
Yeah,
I know we
I
get
know.
4 hours, but I
It
still
goes
feel like
quick.
that's not enough.
It
Yeah.
goes quick. I'm telling you. It really does. A lot of people, because I have a lot of people ask, well, can we take breaks and can we go to the bathroom and can we do all of these things? And I'm like, guys, you're not even going to think about it. You're going to look down, you're going to get through your questions, and you're going to say, holy cow, 3.5 hours have already gone by. I
Oof.
promise
Yeah,
you,
and I have
it's going to go
like
And
faster than you think.
anxiety.
Yeah.
Yeah.
and another on an unrelated note is I'm in the study guide. I finally am on the appendix A practice exam.
Good. Okay.
And but I mean I only started a little. I only did like two questions, but either way, I think even when I'm done with both of these, I still am not going to be ready to take the practice exams because I haven't been ever since I got this job. I haven't been good at practicing coding. In the last few chapters for like the coding from scratch, I had to look at the answer key because I just was really struggling and I had a lot on my mind.
Yeah. Yeah. Just, I mean, and kind of like we've kind of reiterated a couple times, just do it in your own time. Because if you try to go through it and you try to force it, you're not going to retain that information.
Yeah, but I don't know what I'm gonna do. Like if I once I start taking the practice exams again, like if I keep failing them again, I don't know what I'm gonna do.
Yeah. Well, I mean, just you never know how it's going to go whenever you get there. So just try not to think too much about it before you get there. It's one of those
Like
things
like
that,
like what would be your recommendation? Like if I keep failing the practice exams again, do you think maybe I should reconsider maybe if coding is my thing?
I mean, it's either that or either, I don't want to say retake an entire course, but it may be one of those things that you might need to go back and re-review your AAPC material in any of
Well,
those
I didn't.
interactive lectures and see if there was anything that you
Well,
missed while you were going through it the first time.
well, here's the thing. I didn't do it through AAPC. I did it through Ed2Go through UCF.
Okay.
And I've got access to, I mean, I wrote down like a good chunk of the course in a notebook. I don't know if I wrote down all the essentials, and I've got access to that course from that course till Halloween.
Yeah. Yeah. So if you've got if you've got access to that course still, go back through and re-review it and see what material you can re-review in the time to see if you can retain. That I was trying to think of the word. See if you can retain anything else whenever you go back through and re-review it.
Okay. I just feel like ever since, like I said, I've got this job as a biller, I think
Yeah.
I don't know if it just seems like if it's the right thing to do to kind of think, maybe I ought to reconsider my calling, whether I really want to do coding, because considering the fact that
Yeah.
I got a job a lot.
And it could be that billing is where you're supposed to be. It could just be that that's just the way that your brain processes the information. And I mean, there's going to be some people that thought that they would do great in coding and they thought that, that's where they wanted to be. And then once they get into billing, they realize that their brain likes the billing aspect of things besides the coding. So
Well,
just because you decide to go in a different direction doesn't mean that you failed at the road that you were on. It just means that
like,
you just had a
I
different
mean,
direction that worked better for you.
I think maybe what I need to do is I need to think and pray about this, and also another thing too is like, I mean, at my job, I think the only advancing career is like a coding manager. And I mean, I think the thing that causes me to hesitate is like, let's say several months or a year down the road, I start to get bored in this job and feel it becomes too repetitious. That's just the thing
Yeah.
that causes me to hesitate
Well, but I mean that
that,
you can think about that in any job that you're in, right? So that's the thing that you don't want to always think about the what ifs. You always have to just kind of think about, okay, this is where I'm at now and process where you are now, not necessarily think 5 years down the road because you don't know where your brain's going to be in 5 years. So, I mean, it's just kind of one of those things that I mean, you just gotta figure out what's right for you.
yeah, thanks again. I just, like, I just feel like because with some people, like, what would you say, like from like, if you start off as a coder, what are some potential advancing that career could advance to, Tiffany?
What do you mean?
Like, what are some like roles that could get you promoted from a coder to like, what are some like, how, yeah, I'm not sure how to explain it, but like, I'm just curious.
Well, I mean, there's so many different routes that you can take from a coding perspective. Like I started out in risk adjustment coding, and then I moved over to an insurance payer, and I've done auditing, I've done financial recovery. Now I'm in the education space. So that's the thing with coding is once you get in there, then there's so many different avenues that you can take, and everybody's going to take a different just because somebody quote unquote stays at a coder, and I'm using air quotes, right? Just because somebody is in that level doesn't mean that that's not where they want to be versus somebody that was able to climb the ladder faster or to move into a different part of the spider web. It's coding is a um, basically it's an endless possibility. Whatever, there's so many different routes that you can take from a coding perspective to use that knowledge as a coder.
Like, yeah, I think it's just the thing that's hard for me because I like to go quickly. I think it's just reading through those charts, I'm having a hard time grasping because yeah,
Yeah.
maybe sometime you and I could, maybe meet and we could talk more about this.
Okay. Yeah.
Thank you again,
We
Tiffany.
did have another question in the chat. I'm trying to get back up to it. I think, yes, they had asked about number 8. Lakasha, are you still on? Did you drop? I think she did. Okay. Let me see. There were a couple other things that came through here real quick. While I'm looking, I just want to brag for a minute because Carmen, who is on our call tonight, she passed her exam today. So she sent me a message and she passed her exam. So good job, Carmen. I'm proud of you. Let's
Great
see.
job.
Thank you so much, Tiffany. And thanks so for you, for those who really feel that they're not ready, but you put up the work and you just put yourself out there because
Yeah.
I have to say thank you to Tiffany because she actually, I asked her, I said, which part, the ICD-9, actually, look at me, ICD-9, ICD-10, it was my weakest part. And she's like, review chapter 3, chapter 4, chapter 5, and tell me what, that just opened my eyes. And I'm very kind of strong in the CPT, but the ICD was a little bit, and the practice, it did help out. It did. I don't know what was my percentage because I just received the email said you passed, but I don't know how to get, how do I know what percentage I got? I'm really
So
curious.
on the right-hand side on that screen that you had sent me, all you have to do is click on the pass. And once you click on that hyperlink that says pass, it will open it up and it'll tell you your overall score, and then it'll tell you a breakdown of each one of the sections where you got.
Oh, great.
Yeah.
Yeah. Okay. Thank you.
You're welcome.
You, Tiffany, because and I joined the class and I went to Tiffany one-on-one. And we really tackle like my deficiencies and really the integumentary was one of the things that that was the beast. Oh my goodness. The test on the integumentary. I just flagged them and looked at them at the end when I was kind of like, I flagged them and I don't like them. And then but let me tell you, when I was actually done at the end, I put my work into it and everything is clear. When you're there and you actually on the mission of passing, feel comfortable and really reassure yourself that you got this. And don't get scared. Just go for it because you got this. Don't just, that's all I can say.
Yeah. Well, and I said it the whole time that we were meeting, Carmen. I said, you know what you were doing. It was just a matter of getting your brain to realize that you knew what you were doing. And that's when I do individual coaching with a lot of people, I think that's the struggle, is not necessarily knowing the information, but just being confident that you know the information. There's going to be some things, obviously, that you're going to need to work on. I mean, you guys are learning, you're in the learning stage. If you already knew everything, right, then you would have already been a coder, you would have already passed your exam. So don't hesitate and don't beat yourself up because you have questions and we're doing scenarios and you might say, oh, well, how was I supposed to know that? Or, I would have missed that. But the more scenarios that you do and the more practice that you do, the more confident you're going to get because you're going to not make the same mistakes over and over and over again. Once you make a quote unquote mistake, then write down a note in that code saying this includes, this doesn't include, that you don't use this modifier, whatever it might be. And that's going to help you remember those quote unquote mistakes, right? And to not make those again. And that's how you learn. That's just the learning phase. And that's how you get your brain to retain the information.
Like for me, like what I do, I mean, I've been bad at constantly reading guidelines. I'll start each week, but then like I always restart the other week, but never finish through them. Like when I read the CPT guidelines, I only read like the beginning parts of of the chapter.
Yeah, I mean, you have to
Just,
make sure that you read the whole chapter because really the beginning part of the chapter only covers the section, right? It doesn't cover the whole thing. So if you feel like you're struggling with those CPT guidelines, then yeah, absolutely read your whole chapter because that's where you're going to learn what's included, what's not included, why you're doing some things together, why you're doing some things separate.
I've been doing it wrong the whole time, so I'm done for.
No, you're not. You're not. I mean, you've got plenty of time to get in there and get caught up and learn it and do what you need to do. Don't be so hard on yourself.
Thank you. It's just like, yeah, it's just been hard making studying a priority.
Yeah. I know what it's like starting a new job, and that definitely puts you in a different mindset and all of that. So hopefully once the new position kind of settles, you settle into it a little bit more and you get more in the swing and
I've been in the job for a little over a month now. And I mean, I think that because the thing I'm doing is I'm working for an ophthalmologist as a surgical biller.
Well,
So,
just a little like word of encouragement. I've been in positions where it has taken me 6 months to become confident and to get back into like my normal routine. So yes, a month seems like it, you might need to quote unquote be in, your routine and all of that by now. but you're always going to be learning. Like as you get
I mean, I think the
into,
thing that it's just, I want, like if I am to take the CPC, I just maybe am fearful that by the time I am ready to take it there's going to be fill in the blanks.
yeah. Well, I mean, but
That's
use that as encouragement and motivation. I mean, that's the only thing that you can do. And then if for some reason you don't pass it on your first try, then at that point, you've got another year for that voucher. So you can restudy and get comfortable enough with everything within that next year to be able to conquer the fill in the blanks. Everybody's
Thank
so
you.
scared to fill in the blanks. And I want to just encourage everybody that there's really no reason to be so terrified of fill in the blanks because you're going to have to know how to code from scratch whenever you get into the real world. So it's one of those things that and that's why they are changing the exam is because, you can't rely on multiple choice forever, right? And they want to make sure that if you pass your certification exam, you can go confidently into the real world and say, I don't have to rely on multiple choice. I know how to code. So just keep that in mind.
Sorry, just one quick question. I'm hearing a lot
Yeah.
about fill in the blanks, but my test that I'm taking, the exam, it says it's just multiple choice. Is fill in the blanks for
Yes.
next year?
Fill in the blanks. They have not released when fill in the blanks are coming, but we know that they are. My guess, and this is 100% a guess, and I could be totally wrong, but my guess is they will have fill in the blanks for the 2025 exam. Just because I know that they are not going to rewrite an exam when there's 3 months left of the year. So that's our kind of guess is that the fill in the blanks are going to come in January, but that has not been announced. So I want to reiterate that has not been announced. That is not an official date. Okay. But it is possibly going to be in January. But that's my educated guess, having been in the field for so long and knowing how they structure their exams. I don't think it's going to be for all of the certifications. I think it's only right now going to be for the CPC. There are some fill in the blanks for the inpatient, the CIC. The CIC has been having fill in the blanks ever since it, came into existence. But that, as far as we know, only the CPC exam is going to be changing to fill in the blanks that is currently multiple choice.
Well,
But
thank you
like I
again for your
said,
time.
it's one of those things that's my best guess as to when it's going to come, but it could be later. It could be 2026. We never know. I have no idea. That's just my guess.
Thank
Okay.
you again for your time.
Yeah, absolutely. You all have a good week. Have a good weekend, and I will chat with you guys next Wednesday. If you all are
Thank
in
you.
Florida, please be safe. And if things hit the fan, then just be safe, and we'll talk to you next week.